Welcome to the Alpha Blocker Blueprint, an engineering guide to adrenergic inhibition. We will visually explore the mechanisms, clinical uses, and systemic effects of sympathetic antagonists. We will navigate the adrenergic inhibition circuit by recognizing the mechanisms of antagonism, determining pharmacological actions, discriminating therapeutic uses, and illustrating systemic repercussions. Adrenergic tone is controlled by 4 distinct intervention zones. These include inhibiting synthesis with agents like alpha-methyl-dopa, preventing storage with reserpine, blocking release with clonidine, and receptor blockade. Alpha blockers are classified by receptor selectivity into non-selective and selective branches. Non-selective agents are reversible, like phentolamine, or irreversible, like phenoxybenzamine. Selective alpha-1 blockers include prazosin, doxazosin, and tamsulosin. Alpha-1 blockade forces a systemic hemodynamic shift. The inhibition of alpha-1 receptors causes vasodilation in both arteries and veins. This leads to a drop in blood pressure and an increase in peripheral pooling, which triggers reflex tachycardia. Non-selective blockade triggers the tachycardia paradox. While all alpha blockers cause some mild reflex tachycardia, non-selective agents cause severe tachycardia. This is due to the blockade of presynaptic alpha-2 receptors, disabling the negative feedback loop and causing a massive norepinephrine surge. Alpha blockade unmasks beta-mediated vasodilation, a phenomenon also known as epinephrine reversal. In a normal state, alpha-mediated vasoconstriction dominates. By blocking alpha receptors, beta-mediated vasodilation is unmasked, resulting in profound dilation, especially in skeletal muscle blood vessels. Venous pooling drives the first dose orthostatic phenomenon. Inhibition of alpha-1 receptors forces vasodilation in the veins. Upon standing, blood pools in the periphery, causing a sudden drop in blood pressure known as orthostatic hypotension or the first dose effect. To mitigate this, a small initial dose is administered at bedtime. Alpha blockers are deployed across 5 key clinical pathologies. These include hypertension, hypertensive crisis, norepinephrine extravasation, pheochromocytoma, and benign prostatic hyperplasia or BPH. Tamsulosin exploits subreceptor selectivity for targeted BPH relief. Prostate smooth muscles are dense with alpha-1A receptors, while blood vessels rely on alpha-1B receptors. Tamsulosin selectively targets alpha-1A, causing prostate relaxation with minimal systemic blood pressure disruption. Selecting the optimal agent requires matching profiles to pathology. Doxazosin, a selective alpha-1, is preferred for hypertension due to its long action. Tamsulosin is used for BPH. Phentolamine, a non-selective agent, is used for hypertensive crises, pheochromocytoma, and norepinephrine extravasation. Systemic repercussions of alpha blockade include effects on the head, heart, vasculature, and pelvis. This can manifest as nasal congestion, reflex tachycardia, orthostatic hypotension, and sexual dysfunction. In summary, alpha blockers are classified as non-selective or selective alpha-1 agents. Alpha-1 blockade causes systemic vasodilation, while alpha-2 blockade causes severe tachycardia. Agents are chosen based on pathology, and the first dose should always be administered at bedtime to prevent orthostatic collapse.